Hello, my name is Anne-Marie Kopinski, and I'm from the Northeast Vascular Imaging Group in Albany, New York, and I'm going to present to you today the chronic venous duplex ultrasound examination. We're going to examine the ultrasound requirements for the chronic venous insufficiency examination today. I'm going to take you through the areas that need to be evaluated, as well as talk about diagnostic criteria and some of the variations in terms of treatment for chronic venous disease. If you don't work at a dedicated vein center, you may never encounter a patient like this one here. This is a patient with a venous stasis ulcer. We can see it's really red and weepy and bloody. We can see the discoloration on the skin as well. And this certainly is the end result of chronic venous disease, something we want to prevent because it does have pretty severe debilitating effects for the patient and their lifestyle. Most of us have encountered these type patients with pretty severe varicose veins. Now we can offer a lot more treatment options for them. And what we'll go through is exactly what we can do for diagnostic options. Why do we see so many patients with venous disease? Well, unfortunately, in the United States, about a third of all American women have some level of varicose veins. Only about 19 to 20% of men have varicose veins. However, when we get over the age of 65, varicose veins are present in about half of us, and that's a pretty high percentage for any type of disease. So we will see a lot of these patients in our departments and laboratories. Doing the math, about 6 million Americans will present with skin changes alone that are consistent with chronic venous insufficiency, and about 500,000 Americans have venous stasis ulcers. So this is a pretty widespread phenomenon, so we will see these patients a great deal. Well, how do we perform the venous insufficiency examination? It all comes down to really looking at the valves and assessing whether or not the valve is functioning. In this image up here, we see a valve open. Down here, we can see pressure applied to the back of the valve. The valve is now closed. And this is exactly what we want to be able to reproduce at various levels in the limb to make sure the valves are open or closed. Now, you've probably seen this schematic a number of times before. This was borrowed from an earlier article by David Sumner where he talked about hemodynamics. And I put this in to illustrate the fact that we need hydrostatic pressure here to help us generate pressure against those valves. If we're supine, we use the heart as a reference point for all pressure measurements in the human body. And if we're supine, the venous pressure is about 0. So if we stand up here, we add hydrostatic pressure because we've created the effect of gravity due to the fact that the veins down at the ankle are a set distance away from the heart. And in about a 6-foot individual, give or take, that pressure gradient is now 100, give or take, millimeters of mercury. So if we were supine, the pressure at the heart is 0. The pressure at the ankle is about 15. Obviously, blood flows down a pressure gradient, so it goes from 15 to maybe about 5 or 10 to about 2 or 3, back to 0. But now we've added 100 millimeters of mercury when we've stood that patient up. So we've got about a 7-fold increase in venous pressure, which is great and helps us do our job to push pressure against the valves and see if we can make them not work. This cartoon borrowed online here just illustrates again the effects of hydrostatic pressure. The surface of the water is the reference point in this illustration, just as if the surface of an ocean is a reference point for a deep sea diver. And we can see the pressure nearer the top of the barrel here is not so far, because the water doesn't stream out so far. But lower down in the barrel, as we've increased that distance and increased the effect of gravity on pressing down on that column of fluid, we've actually got higher pressure at the lower barrel, and we can see this stream of water go further. This is another slide that I've shown before in the past, and it illustrates the effect of hydrostatic pressure as well. Here's a styrofoam cup we have in the center, our favorite Sharpie marker along the bottom, and these two objects are actually also styrofoam cups. They were tied to the outside of a deep sea vessel and brought down to about 2,500 meters, which is about 8,000 feet, give or take. The pressure of that weight of the ocean on that styrofoam cup actually squeezed out all the air from the cup and collapsed it down. So that's a pretty phenomenal effect of hydrostatic pressure, and we want to do something like that when we examine our patients. We have to maximize venous pressure. Really, the ideal position is standing. If you can get good results standing, you know you've done the best thing you can do for your patient. Now, sometimes some patients are not in shape to stand for long periods of time, so we can do them in a reverse Trendelenburg position. It's okay, but if you have any doubt, we have to stand the patient up. Certainly, we want to observe proper body mechanics. A height adjustable bed is essential. We want to position so we're scanning either right at our side here or in front of us. We don't want to reach behind us. If we're scanning down the leg, we want to step back, move the equipment back with us, and follow along. A lot of people ask, how do we do this with a patient standing, and how do we get through this exam? Here we have our technologist sitting on this step stool here, and she's leaning forward, her back is bent, her neck is cocked here to the side, and she's examining the mid-thigh area in this subject. However, this is totally going to wind up with her needing a massage, if nothing else, because she's going to produce a lot of strain on her neck and shoulder and back. We've changed from this stool to a step stool. She's lower down, so she's at a better position here to examine the thigh. We've moved the equipment down in front and lower, so now she's much more ergonomically adjusted so she can complete the exam. When you're through with examining the thigh portion of the leg, when you have to go to the knee and lower, then you can move the bed up, have the patient dangle their leg over the side, go back to a regular task chair or stool, adjust the equipment again so it's at the proper height, and you can complete the evaluation of the calf area. Now, in terms of hemodynamics, this illustration shows how normal blood flow happens in the lower extremity. We have a deep venous system here and the superficial venous system here, and they're connected in between by perforating veins. If we take a step and contract our calf muscles, blood heads north back up to the heart. And when we relax, these valves close both in the superficial and deep system to prevent blood from falling back down, so that blood fills the venous system, only coming over from the arterial side of the circuit. Now, when we see patients with varicose veins, what happens is we still take a step, everything heads north to the heart, but when we relax, some blood comes over from the arterial side, but some blood falls back down, because now we have incompetent valves along the saphenofemoral junction and within the superficial system. So this prevents the blood from moving only in one direction, and it actually moves in a retrograde fashion, filling these veins. The increase in volume results in an increase in pressure. The veins dilate, they become tortuous, and we see the classic presentation of varicose veins. Now, the worst case scenario is where we have not only incompetent superficial valves, but we now have incompetence of the perforator valves and maybe some level of obstruction within the deep system, some sort of latent chronic DVT that we don't know about. So what happens is we take a step and some blood goes up, some blood goes out the incompetent perforator, some goes down the incompetent deep system, and when we relax, you can see some blood flows down, some comes in, and it's all this very circular motion of flow, so we can't empty the calf properly. We never reduce that volume and that pressure, and it sets us up for what can eventually become chronic venous insufficiency with ulceration. So in the ultrasound departments or vascular labs, our job is to detect chronic venous insufficiency in these patients. When we evaluate for venous insufficiency, we have to figure out what kind of pathology is involved. Is it strictly reflux? Is there some DVT present? Is it a combination of both? And what anatomy is involved? Is it the superficial, deep, perforating veins, proximal, distal? All those questions have to be answered by ultrasound. Again, here's a patient with a venous stasis ulcer, and you can see the marked pigmentation and the varicosities in their leg. Now, a complete protocol will involve all three areas. Sometimes clinicians have seen the patient before, they know what's going on, and they can focus you in on a particular segment. But in terms of the deep system, we'll evaluate for DVT, as well as look for reflux within the common femoral and popliteal veins. We don't usually include the tibial level veins because there's really not too much that can be done for those vessels in terms of correcting that valvular incompetence, so many people choose not to scan those. We also look at the superficial system, but there we really need to evaluate the entire length of the great and small saphenous veins, and also perforating veins. And in this kind of a patient here, many of the perforators involved will be in the region of the ulcer. This ultrasound image just shows a normal venous flow profile. We can see flow and then no flow. We see tiny little bit of retrograde flow here, and that's normal because as flow comes up towards the heart, the valves open, and we need just a little bit of back pressure to engage and close those valves. So this tiny little bit of amount must be less than half a second, and that's normal valve closure phenomenon. In this example here, we can see this portion of the flow profile is actually retrograde flow. We can see we're angled up towards the heart, so flow's moving in this direction, back down the leg. It's going to present a positive Doppler shift, and that's what we see here. This is about a 4-second sweep total, so this is about 2.5 seconds worth of reflux. As I said, with the deep system, we're going to look through the whole femoral vein, stopping and taking images along the way. We want to see flow and then no flow. This is a little bit of augmentation, no retrograde flow, so that's a nice competent femoral vein. We continue all the way down. We can use our color to help guide us, particularly in the deeper vessels. And again, that we want to confirm what's going on with our spectral Doppler. The last level of the deep system, as I mentioned, would be the popliteal vein, and we can see that here. The popliteal vein, again, nice normal phasic flow with no retrograde flow. Now I put in this slide to remind us that we really need to adjust the equipment with reflux studies. We really want to set the Doppler scale or PRF such that when we augment, we produce aliasing, as illustrated here. And then after we produce that augmentation, we see this long, low level, low venous Doppler flow profile here, which is indicative of reflux. Sometimes these velocities are very, very low, so we really need to adjust the system appropriately. Now, some folks use just manual compression, squeezing the limb in order to augment flow, pushing that flow past the transducer, waiting, listening, and looking. However, some folks don't like that. And years ago, Dr. Paul Van Bemmelen, when he was at the University of Washington, published this paper which said, well, you know, squeezing is good, but let's try to standardize it. So he said, let's put some various cuffs on the limb, inflate them to certain pressures, greater pressures as we move distally in the leg to account for that hydrostatic pressure, which increases distally. Let's inflate the pressure and then rapidly deflate it and look and listen. So this is a standardized way to augment and look for reflux. Some folks do this and find that it works very well for them. Now, what about the superficial system? That's really what clinically we can see a lot of varicose veins in these patients. We'll start at the saphenofemoral junction, which is illustrated here. Here's the great saphenous vein emptying into the common femoral vein. Color-coded in blue, flow is going all the way back up towards the heart. So that's normal antegrade flow. In this slide here, we see two examples. We have the patient Valsalva, which is obviously something that some folks have difficulty with. So it's important before you start your venous examination to have them practice doing that Valsalva maneuver. We have them Valsalva. We see virtually no color flow, just a little blip here, but this is a competent saphenofemoral junction. As compared to this example on the lower right, we have them Valsalva and we see the orange reddish color here, which is indicating flow towards the transducer, which is reflux. Color is great and color can rapidly identify reflux, but I would recommend that we actually still do spectral Doppler as well, putting in our spectrum and looking at and being able to measure the reflux time. All the equipment can do this. In this example, our reflux time is almost 3 seconds. Most folks have gotten away with trying to grade severity of reflux, saying that maybe a half a second to 1 second is mild, and then 1 to 2 is moderate, and greater than 2 is severe. Pretty much nobody uses those kind of systems anymore. And in general, folks use a half a second of reflux as being significant. Some folks will use 1 second, particularly in the deep system. This slide illustrates the normal anatomy of the great saphenous vein. It's usually encompassed in a fascial boundary. We can see this bright white line here, which is fascia, and this white line underneath it. So it's sort of wrapped here. And if you look at this, it kind of looks like a little eyeball looking at us here. Here's the eye staring at us, and here's the eyelids. That is the normal planar arrangement of the great saphenous vein. However, there are numerous tributaries, secondary branches, that will move up and out of this plane. They can have venous insufficiency and need treatment as well. So it's important to identify tributaries versus the main trunk, and the main trunk usually lies in this fascial plane. The other thing I note here is vein diameter. In this case, it's 7.4 millimeters. This used to be important in determining the size of catheters that some physicians use for ablation procedures. However, it's not quite as important, but some insurance companies want that information. So you may still be required to measure vein diameter in the superficial system if people are undergoing ablation techniques, which we'll talk about in a minute. Here is just another example. Again, we're angled in on this very kind of flat segment of the great saphenous vein. We've got our gain up a little bit so we can try to see low flow. And you just have to be careful that you don't overgain too much and confuse what the real signal is versus what the overgain signal is. Now, in many examples, I've put in the angle correct feature on the equipment, even though it's a venous study. And basically, we don't care about the absolute velocities. We care about the direction. However, this really promotes us to use a good angle. If we see it, we try to keep to 60 degrees, because if we get too far off 60, we're just going to decrease the Doppler signal so significantly that it'll make our job a lot harder. In this example here, I've turned the angle off so you can see we don't have an angle correction, but if we were getting too far off 60, we would not be able to pick up this signal as well as we are here. Okay, what about perforators? Well, perforators are small veins that connect the deep and superficial systems. Sometimes they directly communicate with the deep systems, such as the popliteal perineals, posterior tibs, or femoral vein. They're a straight shot through to those named veins. And sometimes they're actually just vessels that connect into various muscular tributaries or even the soleal veins. But they all have valves, and they all have, should have flow only in one direction. This slide shows some common locations for perforating veins, usually in the middle thigh, upper calf, lower calf. Some are branches straight off the main trunk of the great or small saphenous, and sometimes The perforators come off of branches, so there's a lot of variability. Clinically, in patients with ulcers, we see usually 3 to 5 that are relevant in those patients. This slide here is just taken from an anatomy textbook showing again the level. They all have names. These are the Dodds perforators, the Boyd perforator right around just below the knee. The Cockett's perforators are very important in the lower calf. They all have names. It might be nice to know the names. It's much more important to know where they're at and if they're working well or not. We're going to use ultrasound to identify the perforators in one of two ways. We're either going to follow the great saphenous or the small saphenous and look for branches that trail down and away deep in the image, or we're going to look at the deep veins and look for branches that come up and connect into the superficial system. We'll use color imaging or spectral Doppler again to determine flow direction. We can use some compression techniques to augment flow back and forth, and we'll want to look for flow in the wrong direction again that lasts more than half a second. Here we have a good color image of a perforating vein here. We don't really see the great saphenous too well because we're sort of off plane, but we can see the pathway of this perforating vein, and it's color coded in blue, so we know flow is going away from us, as compared to this vessel, which is color coded in red, and it's coming up. The flow is coming up towards this great saphenous sitting up here. So this is retrograde flow, and this is an incompetent perforator. We have to be careful because the perforating veins do have a small companion artery, and you can see that flashing at times, and it might confuse you. But again, the veins usually have a lower flow states, more continuous color appearance to them. Many of us also choose to measure the diameter of the perforator. We usually try to measure that about where it cuts through the fascia. Sometimes some physicians will elect to ligate perforators based on size, even if we can't determine insufficiency by ultrasound. In this example, this calf perforator is almost 4 millimeters, so it's likely to be incompetent. When we're evaluating perforators, if someone's going to have a perforator ligation, we'll mark the skin right where the perforator penetrates the fascia. As I said, we also record the diameter, and we'll make a note if there's a lot of wandering going around or if the vein comes off obliquely. Those things are important, again, when we're planning interventions such as a ligation or a vein ablation procedure. This paper was almost 10 years old, but published in JVS several years ago, and talked about, again, the size of the perforator, that once you get up 3.5 or close to 4 millimeters in the calf, that vein is likely to be incompetent, even if you can't generate incompetence on ultrasound. And once we get above 4, close to 5 millimeters in the thigh, that vein is incompetent as well. Now, during ablation, what are we going to do differently? Well, we're going to mark the great saphenous vein on the skin as an access site for entry into the vein, usually in the lower thigh or knee or upper calf area. And using our ultrasound, we're going to guide the insertion of the guide wire and the devices into the saphenous vein. We try to get a little bit away from the saphenofemoral junction because we want to leave the superficial epigastric vein intact. In this slide, we can see that tumescent anesthesia has been injected. We can see the very echolucent area of the fluid, kind of looking like edema. It does two things. It first acts as anesthesia, and then secondly also acts as a heat sink to prevent any damage from the skin. We can see as well here that the catheter is in place in the saphenous vein, and this fluid has actually compressed the vein around the catheter. After we've done ablation, folks usually follow their patients. Certainly an early post-procedure ultrasound evaluation is essential to rule out the presence of venous thrombosis in the deep system. Some folks just do that one scan and never follow the patients again. Other folks choose to serially monitor their patients. That's going to be a matter of departmental policy. What we want to see is post-ablation, that there's echogenic material within the vein, that there's no color flow within the vein, And over time, this vein will become atretic and shrink down and basically look like a fibrous cord. And in some individuals, we may not be able to detect it. Here is an image of a vein that's post-ablation. This has all been ablated. It's fibrotic, not thrombotic. They don't like us to use that word. Following an ablation procedure, we can see the common femoral vein here and a little bit of flow still through that saphenofemoral junction, which is essentially coming through the superficial epigastric vein. This is what we don't want to see. We don't want to see thrombus here extending down through the saphenofemoral junction. This is obviously a potential problem for embolic disease and pulmonary embolism. This image shows a very, very thin fibrous cord where we can barely make out what was the great saphenous vein post-vein ablation treatment. So to conclude, venous ultrasound is certainly a very good tool to evaluate patients for venous insufficiency. Spectral Doppler will rapidly identify venous reflux. We're going to use criteria of greater than half a second to indicate that valvular insufficiency. Color is a great tool. It rapidly identifies the direction of flow. If we're dealing with perforators, we may want to mark on the skin where the perforator penetrates the fascia to aid in the treatment of these perforators. And we're not only going to use ultrasound to diagnose venous insufficiency, but we're also going to use ultrasound during treatment procedures such as vein ablation and also to assess status post-procedure. Thank you very much.